So, good afternoon, all. A warm welcome to all of you. Today, we are here to discuss an important topic, very pertinent to all, especially the all female panelists which we have, her health and her power. And I'm Dr. Monika Shashank. I'm medical director with Dr. B. Lal Laboratories. And Dr. B. Lal Laboratories keep on organizing such kind of programs under the topic of DocTalk, where we engage the clinicians, where we engage the medical fraternity to talk about health of the human being and the patients and how we can make an impact in improving that. So today in the panel we have Dr. Girija Wagh. She is a renowned gynecologist and IVF specialist from Pune. We have Dr. Tina Jubin, who is Assistant Medical Director at Abbott India. She is from Mumbai. And we have Dr. Monika Agrawal. She is the Lab Director at Dr. B. Lal Clinical Laboratory, Jaipur. So we have pan-India presence from the panelists, and the same I expect for the attendees as well. So why we chose this topic? Because it's very, very pertinent, and we know that in due course of time we will be having a International Women's Day also. But then, having said so, women are the key pivotal people at the family. They are not only involved in maintaining their family, but they have an important role in maintaining a society and to the contribution towards the nation. So I was going through some studies and the statistics. So what I found that women definitely they keep on neglecting their health, and what happened is that they are 25% more of their lives. They spend in worse condition than men, which is a study from the World Economic Forum and McKinsey Health Institute. The same study shows the importance of women in keeping the economical growth of the organization or the nation for that matter. So what that study says that $1 investment invested in women's health would return around $3 in the economic growth of the nation. So this is a very important part of it. And again, coming to the various reasons of women health where they are neglecting and which is a more pertinent cause is the cardiovascular health diseases and the cancers. So I'll start my discussion with the cardiovascular diseases with Dr. Tina Zubin, where she will be talking about bridging the gap in identifying the cardiovascular diseases in women. And why cardiovascular diseases? Because it is the most common cause of mortality among the females worldwide. So, Tina, I would like to understand from you. Definitely, we know the CVD is an important part of it, and usually females suffer from the during the gestation period from the preeclampsia, gestational diabetes also, which leads to the cardiovascular diseases eventually in their life. So, what are the factors which are contributing to that? How we can go for early diagnosis, and how we can prevent it also? Over to you, Dr. Sinazabi.
Thank you so much, Dr. Monica. And on the onset, uh, good evening to everyone, and also a warm good evening to my fellow colleagues as well and the panelists. Please allow me to share my screen. Is my screen visible?
Yes, it is visible.
Okay. So like Dr. Monica said, women are known to be caregivers all their life and they neglect their health a lot. And we always have this concept that more prominent diseases amongst women are cancers and other gynecological disorders, right? But that is still a myth. So just looking into the cardiovascular diseases, I would speak how we can identify earlier, so act earlier and therefore prevent the worst outcomes that could be caused because of cardiovascular diseases. So if you look at the background worldwide for cardiovascular diseases, it is the number one cause of death globally. And it accounts for almost 30% of global deaths. And the projected mortality, if you look by 2030, it's almost 23.3 million. So that's why this comes to, I get this question whether cardiovascular disease, is it a women's disease? We always put it as man's disease, and we say that we have the estrogen protective effect. But if you look at the facts, cardiovascular diseases is the leading cause of death, both in men and women worldwide. Specifically, looking into the prevalence in women, it is responsible for almost 35% of deaths in women each year, more than combined of all the cancers. And young women are more likely to die following a heart attack than young men. And look at the number or the mortality. It's 1 in 3 deaths in women are caused by CVDs. So the prevalence is really high, and there is certainly need for preventive measures, certainly need for regular screening, and as well listening to your body, listening to the signs and symptoms that are there. So if you look at the risk factors for cardiovascular diseases in women, we have certain very well-established risk factors wherein the top of the chart is hypertension, followed by dyslipidemia. Diabetes, of course, is one of the leading risk factors, and obesity, unhealthy diet, sedentary lifestyle, so lack of physical activity, smoking and tobacco use is also one of the leading established risk factors. But along with these, when it comes to women, we have some sex-specific risk factors also, which add to the complications like premature menopause, gestational diabetes, as mentioned by Dr. Monika. Then we have hypertensive disorders of pregnancy, PCOS, which is very, very prevalent now. And of course, certain under-recognized risk factors like the psychological risk factors, socioeconomic deprivation, and so on. So that's about the risk factors. Now let's look at the signs and symptoms. Again, a myth which is there. So I got these very cute myths and fact pictures from the World Heart Federation, where we say that heart attack symptoms are identical for men and women, but it's not the same. Chest pain is the primary symptom, but when you look at women, they are more prone to experience shortness of breath, nausea, vomiting, jaw pain. So there is certainly a difference, but whatever the symptoms may be, we often neglect it. We often think that, okay, it's a regular pain that is caused because of the daily activities, and often it is ignored, leading to worst outcomes. So women with CVD continue to be underdiagnosed first, and because there is underdiagnosis, there is the treatment is also poor. So how, from the lab perspective, from the lab, as like when we look at Bilal has put forth this particular webinar. So as the laboratory fraternity, how can the lab help? That's what we look at. So when you look at the testing for these heart attack or for any CVD, most prevalent testing that is done is the echo, the ECG, the cardiac catheterization, and very, very importantly, laboratory tests. Out of the laboratory tests, we know troponins play the major role. It's the cornerstone for acute coronary syndrome diagnosis. We all know that there are 3 types, which is there, the troponin I, troponin T, and C, wherein troponin I and T are most widely used for diagnosis and in the emergency setup. So today we see at very important 2 perspectives how we will diagnose and how we will predict using HS troponin I. So we have multiple troponins available with us for use. We have those cards, we have troponins, which give you a positive and a negative. But something here over that you see is high sensitive troponin I. So if you look at the guidelines by the European Society of Cardiology, they recommend the high sensitive cardiac troponin. Why? Few reasons that they have enlisted. This is from the guideline. First being, as compared to the standard cardiac troponin assays, the high sensitive assays have a higher NPV, negative predictive value. So you are more sure about your ruling out. Second, it reduces the troponin blind interval. Now, what is this troponin blind interval? We know when a patient comes with chest pain, we often do repeat sampling, and initially in the olden days we used to wait for 8 or 6 hours and do a second repeat testing for troponin. But now with the advent of high sensitive troponin I, you do not need to wait until 6 to 8 hours, but it's as short as 1 to 3 hours, and that would give you accurate results. So the troponin blind period that was there, that has been reduced because of high sensitive assay, and you are able to accurately diagnose type 1 and type 2 MI. Now, because it is high sensitive, a very important point over here is it is common to detect circulating levels of cardiac troponin in healthy individuals. So before maybe a decade back, we would not get troponin values in healthy individuals, but only someone with a chest pain would get these values, right? But now with high sensitive troponin, that is not the case. Now, what has changed? This is the normal curve for high sensitive troponin. And the contemporary troponins that we have, the older generation ones, they had a very, very high limit of detection, meaning only when there is a cardiac ischemia, there would be a rise of troponin, very elevated levels would be there in circulation, and those high levels could be detected by the assay. However, now, and the 10% CV, that is the coefficient of variation, that was way beyond the 99 percentile or the cutoff, leading to inaccurate results. Now, what has happened is with just a second. Now, what has happened is with the advent of high sensitive troponin I, the limit of detection has reduced a lot. If you see, it is as low as it has moved towards the left. It is as low as 1.9 picogram per ml, and because of which troponins as low as these values, which are there in the healthy individuals, are also now detectable. And if you look at the CV as well, it is very well beyond the 99 percentile, therefore giving you more accurate results. Now we know troponins are used. High sensitivity is more recommended. Now, how is it helpful in women? For that, I would like your attention to this particular study where from the University of Edinburgh, where they found out that there is underdiagnosis of MI in women, especially troponins being a major marker that is being done. We know the cardiac muscle mass is lesser in females as compared to males, but the cutoffs that we were using initially were the same for males and females. Now, if you look at this particular graph over there, what did the authors do is they first used the older troponins, one single cutoff for the subjects, and they found out that when the old assays, not the high sensitive one, the older, less sensitive assays were used, there was an 11% diagnosis in females and 23% diagnosis in males. Now, the same subjects were tested using a high sensitive assay, but um, the high sensitive assay, but a single cutoff, a common cutoff for both males and females. But you see, because it is high sensitive, you see an increase of 5%. So a 16% diagnosis is seen when you use a high sensitive. Now, adding to that, when a gender specific cutoff, they did a reference range study and they found out that the cutoffs are much lower for females, and that were applied to these subjects, and they found that there was an increase to 22%, clearly showing that one of the reasons for underdiagnosis was that a sex-specific cutoff was not being used. And I can proudly say that Abbott was the first one to get these gender-specific cutoffs for diagnosis of AMI in females and males. So concluding for diagnosis, it will help you in when you use HS troponin I, it will help you in ruling out of ACS with added accuracy. And now you can detect very low levels. So where your negative predictive value is almost 100%. Rule in, like if you have to admit a patient for coming with a chest pain, you have added accuracy. You can give a decision within a span of 1 to 3 hours. You no more have to wait for 8 hours. It is particularly useful in women, where I showed you the sex-specific cutoff, and early presenters, because early presenters would have very low values of troponin, and with high-sensitive troponin, you can detect even in those, and prognostically valuable, and it also fits into the criteria put by IFCC, and we have a very strong body of evidence, many publications in high-impact factor journals, which show that it impacts diagnosis, and women can be particularly picked up in a much better way, and even early presenters. So that's in a nutshell about diagnosis. Now let's see how we can predict heart diseases using the same troponin that you once used only in the emergency. So for that, risk stratification is important. So now it looks like a complicated term. What is risk stratification? By risk stratification, what am I doing? In a group of healthy individuals or apparently healthy individuals, I'm identifying or predicting who is at risk or likely to be at risk. And therefore, if I can pick such people, meaning women may not have symptoms, but they go for regular health checkups. I add a test and I find out who is at risk. I can prioritize the care. This is an alarm for the patient or the for the individual, for the women, that see your heart is showing a certain giving out certain signs. You need to go and meet a cardiac specialist. You need to take care. So what happens when we do that? We can prevent worst outcomes, like in case of CVDs, heart attacks, heart failure, or even death due to cardiovascular diseases. Now, why it is important? This is a WHO chart for projected mortality. This green one is for cancer, this one for chronic respiratory diseases. But if you see, cardiovascular diseases top the chart. And post the pandemic, we all know the risk has risen. And for the Asian risk, if you look, it has risen by 20%. So there is need of identifying earlier so that we can take the preventive measures. Aren't we doing that? Yes, we are doing it. We have for certain tools, like the cardiologists use algorithms like Framingham or the SCORE. The JBS3 and QRISK is the most widely used, where we put multiple variables like the systolic blood pressure, age, sex, and whether you are on hypertensive medication, and it will give you a 10-year risk. Similarly, we rely heavily on lipid profile, as we know, but we know this is lifestyle influenced. It may not give you a direct correlation to the risk of heart disease. HSCRP, once widely called out as a marker which can tell you future cardiovascular risk, but we know it's an inflammatory marker. So it would give you inflammatory status of your heart, but it may not be the specific marker for a future cardiovascular risk if you want to identify. So there are limitations to what we do, like a general correlation, inaccurate risk prediction when you use certain tools, because they are very, very age influenced. So if you are older, it will automatically put you in the high risk, irrespective of your other clinical findings. Then certain cutoffs, like HSCRP, it says that more than one in one of our guidelines is everyone is in moderate risk. But the basal cutoffs, if you see in Indians itself, is higher. So does that put all of us in the moderate risk? So the cutoffs also should be applicable to our particular population. So how can this particular marker called high sensitive troponin I help? One, I don't want to identify at a later stage. I want to identify much earlier. So it should be measurable in healthy population. So high sensitive troponin I, because it is highly sensitive, you can actually measure in apparently healthy women also. Is it more cardiac specific? Yes, it's a part of the myocardium, unlike the lipids or the HSCRP. ESC, European Society of Cardiology, clearly mentioned it as a quantitative marker for myocardial injury. So any rise of troponin, you know that is a marker for myocardial injury. And because now you're using it apparently healthy, it should be robust to potential interference as well. So some interference that would hamper our results I'm talking about. One is biotin. You must have heard a lot. All of us, like the consumption of biotin has risen considerably because it has implications it has effects and anti-aging, and you look beautiful. So the usage has increased. But we are not knowing this biotin is also impacting our test results, because all our tests heavily depend upon the streptodin biotin principle. So such a case had happened with troponin T. Patient coming with a chest pain, and troponin was falsely low. He passed away, and on analysis, it was found that biotin was hampering with the results, which led to low troponin T result. But with the Abbott assay, we use the magnetic particles and the acrodynium molecule. So we do not rely on the streptodin principle. So you can use it for the healthy population as well. Uh, why not TROP-T and why TROP-I? Because TROP-I is more specific. It is unlike TROP-T, which is also elevated in skeletal muscle damage. When you go for renal dysfunction patients, in such patients also, if you compare TROP-I and TROP-T, TROP-I being a smaller molecule is less impacted as compared to TROP-T, which is 37 kDa. TROP-I is 22 kDa. So the impact of renal dysfunction is more when you use TROP-T. And last, TROP-T shows a diurnal variation. So your test results will depend upon the time of sample collection also. Now, someone coming for a health checkup, because you are apparently healthy, may come at any point of time. So we do not want that should impact. So That's how we are showing from the lab. From an analytical perspective, troponin is an ideal marker for prediction. Now let's look at what evidence do we have. We have a huge set, but in the interest of time, I would go through just few of them. This is published in the American Journal of Cardiology, where 9,000 participants who were free from any known severe disease were followed up for 13 years. And it was found that almost 733 of them had an composite endpoint, either a AMI or a heart failure or a cardiovascular death. Now, all women, so again, over here we have, if you see gender specific cutoff, all women who had troponins about 10 nanogram per liter or males who had troponins about 12 nanogram per liter had a hazard ratio of 3.61. What this means is they are 4 times more at risk for a cardiovascular disease as compared to someone who has a troponin below 4. Again, we compared it with HSCRP also, and they found out that just troponin I could give you more information because we are clearly saying that troponin is not to be used as a single marker. It is to be used with other clinical findings and other markers like the lipid profile, the HbA1c. Together, it would give you a comprehensive approach, a comprehensive way of managing the particular patient. So again, it is compared with Framingham as well, which is a very widely used tool for risk stratification by cardiologists. And we found that Framingham is very, very age influenced. But when we use troponin along with Framingham, it put the patient in the correct risk category because when they were followed up, it was found that those with Framingham and HS troponin I, they ended up having cardiovascular specific events. So therefore, the authors clearly say HS troponin I may be therefore better suited for CVD screening in asymptomatic general population as compared to HSCR. Again, one more example where it is added with the ASCVD algorithm. They found out that whenever first you do an ASCVD algorithm screening, differentiate the patient into very low risk and high risk. And then when you add troponins, it led to enhanced risk stratification. You could reclassify patients into the more appropriate risk group. A very interesting publication from Jan 2024. This is in Croatia, where they have included in their heart program. The government has included in the heart program inclusion of troponins. And in women aged, so in this study, women aged about 45 years with no specific symptoms and no history were taken. And 1,000 women. And they clearly showed that, see, if you see over here, we have risk categories. So as per troponin, 921 of them were low risk. And if you see, none of them were diagnosed with CAD or considered for preventive measures. So we have a paper which says that HS troponin I, when you are in the low category or if it is not detectable, it can help you as a de-risking marker. 100 individuals out of these 1,000 women had a moderate risk using troponin, and 3 ended up with a CAD. So 14 individuals went for angiography, and 11 were considered for preventive measures. So it now over here, if you're in the moderate risk, HS troponin I, along with your other comorbidities, can help you as a gatekeeper, whether cardiac specific investigations are needed or not. Now, 13 of them, so 10 nanogram per ml is a very small number as compared to the cutoffs that we have for an ACS-like condition. But even from those, 12 individuals went for angiography and 9 were diagnosed with CAD. So it's a risk identifier also. So they clearly, that's why conclude that elevated HS troponin I is associated with higher rates of incidental, fatal, and non-fatal cardiovascular events. This is the first observational data, and it can reduce the CVD-related burden. So like Dr. Monika said, we can actually reduce the economic burden caused by this because the prevalence is more. So if we can diagnose correctly, take corrective measures, we can reduce the economic burden as well. And they have found it to be cost effective. We did a validation and we clearly, if you see, this is specifically for females. We tested females almost 6,386 and males 4,649. And look at the hazard ratio. So hazard ratio gives you the strength of how strongly that particular biomarker can predict. It is more in females as compared to males. So definitely it is giving you more information because of the sex-specific cutoff that we have, that it can predict more in a much better way and as compared to HSCRP, where it is only 1.13. So again, we have done a comparison with the existing standard of care Framingham. There again, we found that when we do Framingham or the existing standard of care, females are underdiagnosed. Addition of I to the current standard of care helps you to identify women who actually require care. So I correctly selected more patients who went on to have CV events as elevated risk overall. So we have compared again with troponin T, where we have found that troponin T is good for emergency, but when you look at risk prediction, um, if for cardiovascular related diseases, the hazard ratio is more for troponin I as compared to troponin T. Look at non-CV death, 0.92 for troponin I, whereas 1.39 for trop T. So it is a little more non-specific. If you see for cardiovascular related MI or heart failure, troponin I gives you more information. So it's there in the guidelines, clinical chem guidelines also, where the cutoffs are mentioned for stratification. The 2022 ADA guidelines has clearly said that anyone who is a diabetic, obese, hypertensive, or in the stage B should get cardiac biomarkers like high sense troponin and NT-proBNP. If it is elevated, confirm it with chest X-ray and echocardiogram. If it is not elevated, you still do it at least once in a year. So that is the importance that the ADA itself has put up. It is there in the recent standard of care as well. These cardiac biomarkers have to be screened at a regular basis so that you know your risk. We also had a consensus statement published amongst India where almost 20 cardiologists across India from north, south, and the west were taken up, and they had given how can we use this troponin for cardiac risk stratification. This is the risk score for females. The number to be remembered is 4 and 10. Below 4, low risk, 4 to 10, medium risk, and above 10 is high risk. Similarly, for males, it's 6 and 12. So what do we do next? If you are in the low risk with no comorbidities, only your troponin is elevated, all the other biomarker, all the other parameters are normal, then an annual health checkup would do. And this acts like your baseline troponin value. If you're in the moderate risk with no family history, no risk factors, a 6 month lifestyle modification, because there is an impact of exercise seen on the troponin levels as well. Because if your troponin is elevated, your other biomarker, other parameters have to be ascertained that why is this elevation seen? Is there any other interference or not? If not, then 6 to 12 month repeat troponin with intensive lifestyle modification is what has been recommended. But if you have moderate CVD risk with maybe hypertension, or your hypercholesterol or cholesteremic, or any family history, or you are in the high risk, then a 6 to 3 months follow-up is recommended. You need to treat the underlying cause of the risk or highlighted, which is hypertension or reduced weight diabetes. Statin has been proven and published that statin leads to reduction in the troponins as well. And this recommendation lies with the doctor. So he would see into your other clinical parameters and the troponin value, but this would definitely increase the cardiac specificity, the diagnostic accuracy of the particular doctors. So it's published as well, how you can use as step 1 and step 2 in the journals as well. I would end with this particular example, which actually when we launched in India, we had seen what is the impact. This is an annual health checkup of a 45-year-old female who has no history of diabetes. She doesn't smoke, BMI of 25, LDL 85 looks good, HbA1c 6.1. And so it was a part of a study. So she didn't know that a troponin has been done. Her troponin was 7,000 pg per ml. So it's just a biomarker, simple blood test that is being done, which can give you information. I'm not telling everyone would have such elevated values, but it's a simple biomarker. If it can give you an idea of where you lie, where is your risk that lies, it can help you the way you manage yourself, maybe the way you look at your health as well. So we started that mortality due to CV diseases is continuing to rise in women. There is a requirement of risk stratification, and the current tools are good but have limitations. So with the Abbott troponin I, it's a simple blood test which can help you in identifying earlier, so you can take an action earlier. And rather than ignoring that, okay, my hand is paining for some time, I have a jaw pain, or maybe because of the posture I lied down, a simple biomarker, blood test. You don't need to do anything invasive or some costly test. It is a very cost-effective way where you can get a lot of information. So I conclude with stay healthy, listen to your body because it's after all dil ka mamla hai. Thank you so
Thank you,
much.
Dr. Tina. That's really nice. Yes, it is a Dil Ka Mamla, and we need to pay due attention to our heart and just not ignoring the part F. And the best part is that we have a very simple blood test solution, which is HS troponin I, which you can get it tested among all the health packages by Dr. Bila Laboratory, and that is simple test which we can help you in stratifying the risk also, and then we can take a future course of action. So, thank you, Dr. Tina. That was really, really very interesting and very beautifully explained the algorithm as well, how to move about. And we'll take some questions from the audience once we finish up all the
Sure.
speakers and their presentations. We'll move to
Thank you
Dr.
so much.
Girija. Yeah, thank you, Dr. Tina. So, we'll move to Dr. Girija, and Dr. Girija will be discussing on the ovarian cancer. Although it is a little less common, but it is very a significant concern because it's asymptomatic nature where the diagnosis are often late. So, Dr. Girja, I will start with you. Please help us understanding what are the markers of early screening and when they should be taken for ovarian cancer.
Yes. So good afternoon, everybody, and thank you for setting that stage for us. And yes, it's very important that especially at the beginning of the year, we are getting aware about what are the challenges that we have as far as health is concerned. And I want to congratulate this forum for, in sort of bringing forth, especially cancers in context with women, which is a very important aspect because these are the most neglected sort of an sector. And I must appreciate Tina's talk. Sometimes we have also used this SS troponin I in assessing hypertensive disorders related risks in our patients and which have shown us a good result. Additionally, I must also reiterate and say that if you look at blood thinners, which are very commonly given to men, women are always somehow deprived of them. And therefore, it's very important that we start looking at women's health in a different way. So that was just my comment on what Tina spoke. Now, coming back to the ovarian cancer, early screening and detection is what the topic has been allocated to me. And we have to understand that even if it is mentioned that it's rare, it's not so, maybe it doesn't come to us. It goes to, the cancer people more oftenly because it's such an advanced disease or maybe to other pathies. But it is the second most common gynecological malignancy and the leading cause of death amongst women. And the challenging part is women are diagnosed very late. And there are a lot of screening methods which are used, which are not something which have been validated and universally used, but there are now new things coming up which we must open our minds to. And we have to look at patient symptomatology very closely and not relegate it to saying that, oh, maybe she's having something else, but it may be cancer. And what is very important is the ovarian, the tubal, and the peritoneal cancers share the same origin of cell. From the embryonic origin, probably it is determined, and therefore most of them altogether are called as epithelial ovarian cancers. So thus you can see a small little ovary, which is only to be a size of an almond, has turned into such a huge mass in the woman's abdomen, and therefore is the most lethal gynecological malignancy. And here you can appreciate the peritoneal spread, completely distorting the anatomical contents. So in the silent shadows of late detection, ovarian cancer steals precious moments in future. And therefore, we must shine a light on early detection. For in its times discovery lies the hope of countless lives yet to be lived. And that is where we stand because once the cancer gets detected in an advanced stage, then usually it is the 3-4 stage, and then it is a fight between cytoreduction, neoadjuvant therapy, life, and death. Quality of life, unfortunately, is going to be always poor. So, when we look at the ovarian cancers, the most ovarian cancers, nearly 95% of them, are derived from the epithelial cells, with subtypes which include high-grade serous, low-grade serous endometrioid, clear cell, and mucinous. And the remainder arise from other ovarian cell types, such as the germ cells, sex cord stromal tumors, which are a little rarer than the typical EOCs. And therefore, the term EOC came because of the common pathogenesis which comes in all these three. And therefore, usually the high-grade serous epithelial ovarian carcinomas are the fallopian tubes, the peritoneal carcinomas, and the ovarian carcinomas. You may sometimes be surprised that you've done a perimenopausal screening and you find that the woman has now hit menopause, the ovary has become very shrunken. Just 1 or 2 years down the lane, you find that she's come back again with ascites and a lot of secondaries in the peritoneum. And then that keeps us wondering why. The reason is that it not probably didn't start from the ovary, but it was from the peritoneum. And therefore, all these require to be taken into account whenever we are talking. So in my talk today, the two components are early detection and screening, and that's what we are going to focus on. Now, early detection of ovarian cancer can definitely increase the woman's life expectancy because the role is one to reduce the EOC mortality by diagnosing the disease while it is confined to the ovary rather than at advanced stages when the 5-year survival rate is less favorable. And as you can see in the my arrow is showing you that the stage 1 survival would be 89 if you go by the FIGO staging, but stage 2 will be 71, and stage 3 and 4 you can see there's a drastic reduction. And therefore, almost 80% of the patients have lymph nodes or distant metastasis at the time of diagnosis. And that's the reason why we have to look for early diagnosis. And the secondary goal, of course, is the cure rates are found to be twofold for patients in whom optimal cytoreduction. What does that mean? That the tumor size is less than 1 centimeters at the end of the reduction. And this would give a better chance of cure and survival. And the most significant factor associated with optimal cytoreduction is the volume of the disease at the time of diagnosis. And that's the reason why early detection is extremely important. Now, symptoms are very important, and that's something which is now we have started understanding. Is historically EOCs were called silent killers because symptoms were not thought to occur until very late in the course of the disease. But the advanced EOCs typically presents. There are producing symptoms like abdominal distension, nausea, anorexia, or early satiety due to the presence of ascites and omental or bowel metastasis. Dyspnea is usually present due to pleural effusion. And studies have found that symptoms occur in many patients even at early stages, and therefore be very, very categorical, a little more proactive in trying to diagnose and reach out to find out whether it's actually an ovarian cancer. So when we look at the prevalence, strategies for early detection should have high sensitivity of more than 75%, very high specificity of 99.6%, and the positive predictive value of more than 10%. So these are the typical symptoms that we have been talking about. Urinary frequency. So any kind of abnormality, women will not leave their work and come to your consulting just like that. When they come to you with symptomatology, try to pay attention to them. And this was found, you can see in a publication in 2000, the Goff Symptom Index, which is a screening tool for ovarian cancer that identifies symptoms that are associated with the disease, such as pelvic or abdominal pain, bloating, difficulty in eating or feeling full quickly. And a woman is considered positive on this index if she has any of these symptoms that are new and occur more than 12 times per month within the previous 12 months. So this is for all those clinicians who are in this webinar, that be, very sensitive to these kind of symptoms if the woman is presenting, and try to get at the bottom of it to diagnose. Probably it may be an ovarian cancer sign or a symptom. And if you look at this particular index, you can see that sensitivity is 56.7% for early stage and 79.5% for advanced stage cancer, 90% for women more than 50 years and 86.7% for women less than 50 years. And additionally, if you try to put it alongside with the biomarkers, maybe you will be able to improve their early detection, or even screening is the proposition which I'm going to be speaking about as we go by. So it's very important that we consider reducing, to look at this. And this was a report from the Australian, what happened? I don't know. Something happened in my screen.
Ma'am, we are able to see reducing time to diagnosis does not. This is the report.
Yeah. But something, some addition, annotation आया मेरे इसके ऊपर. I don't know how. How did I manage that? Are you able to
Now
see
we
the
can.
slides
No, no, not now.
now?
Now again back. Yeah, we
Yeah.
are able to see.
Yeah. So then you can see that these are the study group from the Australian Ovarian Cancer Study Group, where reducing time to diagnosis does not improve outcomes for women with symptoms of ovarian cancer. So you can see that 1,463 ovarian cancer patients were studied, written questionnaire was given, phone interview, 81% had invasive cancer, 19% borderline ovarian tumor, and 71% stage 3, 4, and 29% stage 1L. So it's not about reducing the time of diagnosis, it's all about early diagnosis that is very important. And usually, if you can look from the time from the first symptom to the first doctor consultation in months, you can see that sometimes it can be extremely late that the woman would come to for the diagnosis. And therefore, we have to be very cautious and work on them diligently whenever they come to us with any kind of symptomatology, because that can be a sign suggestive of ovarian cancer. So you can see again, people have gone and studied these time periods for diagnosing and coming to a conclusion. So once EOC is sufficiently advanced to cause symptoms, its clinical course is determined and efforts to improve diagnosis do not improve survival. It is possible that early stage disease and borderline ovarian tumors have different molecular genetic features which are diagnosed while asymptomatic and will probably stay confined to the ovary. And that is the foundation of screening. Now, can we screen by doing a pelvic examination? Is the oft asked question. But sensitivity for finding pelvic mass early is only 45%. Annual pelvic examination, 1 out of 10,000 cases. And once a mass is palpated, usually it would be in an advanced stage. So can we use the tumor markers? We know there are tumor markers for so many things. And you can see here, there are tumor markers for cancers. And especially for the ovarian cancers, you may have tumor markers such as the CAE, CA125, AFP, and beta HCG. They may not be typically categorical, and they would come only as better as prognostic markers when the patient has already started on therapy. CA125 is something that we solely depend on for the simple reason that it is secreted by the coelomic epithelial cells, which is a common cell line in the EOCs, and it has a role in carcinogenesis and metastasis. The levels of more than 35 units per ml, 90% of serous EOCs would have that. And however, elevated levels were found in 50% of early stage disease, though not non-specific, specificity is about 99.7, and positive predictive value is about 16%. So at least when the CA125 comes positive, we can proactively start looking at this patient and put her under that risk tag and maybe evaluate and rule out the ovarian cancer. So when we are looking at screening or diagnosing the early stage ovarian cancer, then we would be, if you consider CA125, we understand that it is non-specific because it would be raised even in patients of endometriosis, tuberculosis, any kind of peritonitis, pancreatitis, cholecystitis, and so many other reasons. But it would still help us in guiding to look at that patient. Why? Because many times in EOCs, dysgerminomas, Sertoli Leydig cell tumors, granulosa cell tumors, tubal endometrial and endocervical cancers, you may have elevated CA125 level. Of course, there are benign gynecological conditions which are also contributing to CA125 levels, and non-gynecological conditions as well, and also certain other non-gynecological tumors as well, where CA125 can be raised. So therefore, then there has been an understanding, can we use the HE4 as an extra biomarker to CA125 to improve the detection of ovarian cancer? And is it now the time to step forwards? So you can see here that serum CA125 and HE4 in picomoles per liter concentrations among histological types of ovarian cancer, you can see they are much raised in the serous, the mucinous, the clear cell cancers, and the endometrioid cancers as well. And its concentrations in normal women and patients with benign and malignant ovarian tumors have been studied. And you can see that they are significantly raised in women who have malignancy. And looking at the transitive phase of the woman, it's always smarter to take them whether the menopause is something which is taken as a cutoff. I'll be coming to that as we go by. Now, typically, the question which is asked is, can we do, and this is something which I tell to most of my friends and my patients, if you have access to care, please go and have an annual transvaginal sonography. Now, does it really help? So, if you look at findings of the 25,000 women who were screened, and this was the study algorithm which was performed in these women, where it was found to be normal, then the repeat TVS scan was done, and then it was repeated whenever there was any abnormality found at 4 to 6 weeks, and then accordingly, biomarkers also were done, and then further they were kept under uh, a scanner if whenever they found any abnormality. And various kinds of morphology indices were used in the tubal structure and which were identified. Now, in the risk assessment, prediction of dignity, ultrasonographic morphology, RMI score, ultrasound morphology, CA125, menopausal status used to be taken into account. And what we are talking today is the Roma score, where we can use the CA125, HE4, and the fact that the woman is menopausal or not menopausal to interpret this particular study. So, ovarian cancer population screening and mortality after long-term follow-up in the UK collaborative trial of ovarian cancer screening. This was a randomized control study published in 2009. I'm sorry what happened to my slides. I really don't know. And it was found that if you use only CA125 and the ultrasonographic parameters, maybe your sensitivity and specificity would not be up to the mark. But if you try to put it across along with the HE4, you will be able to identify these things better. So there are various such studies which are conducted in various parts of the world. The Placo study, the Koyabashi study, the Wagner study in 2007, the UKCTOS's USA study, and the MMS group. And it was found that whenever the strategies were compared, and what were the strategies that were used? One was ultrasound. In one of them, there was a physical examination ultrasound as well as CA125. The number of women screened were quite significant. Mean number of screens per women was found to be, as you can see here in the picture, with when we use everything in collaboration, then the chances of detecting them is a little more increased. And you can see that there are various kinds of cancers that were diagnosed, and the apparent sensitivity and the specificity, which was found to be in this particular single arm prospective study, was 76.3% to 98.7%. And while here you can see that CA125 interpreted by ROC algorithm alone was taken into this particular study, and they found that the apparent sensitivity was 89.5% and the specificity was 99%. While you can see that it is a very varied kind of a study where nothing can be compared head on head in amongst this particular population. Likewise, we'll not go into the Placo study. So, what are the things that we have when we talk of screening? One is doing a transvaginal sonography, a high sensitivity 95% for early stage ovarian cancer, low specificity 10 to 15 laparotomies or laparoscopies, and this would be unnecessary, but then they will help us in sampling. And for each case of ovarian cancer detected, this would be happening, and color flow Dopplers would add to this identification. So what do we do? For the first stage cancer, symptoms, ultrasound, tumor markers, and multimodal screening. There is no effective test for early stage disease and the stage duration is too short. And there is no evidence that any of the screening methods affect mortality rates, not cost effective. And then it also boggles down to the fact that let's look at the correct rules of identifying the morphology on ultrasound. And this is what was proposed. The original simple rules of 2008 got modified recently under the International Ovarian Tumor Analysis, where the M rules and the B rules were followed as structured sonographic parameters based on which one could then identify whether it's a malignant tumor. You can see all these red are the suspicious morphological features, while all these greens are the benign morphological features. And based on this came the ADNEX model, which was a risk prediction model that can reliably distinguish between benign, borderline, stage 1 invasive, stage 2, 4 invasive, and secondary metastatic adnexal ovarian tumors. But this was after the ovarian cancer occurred. And the summary classification of simple risk classification was done in about 5,000 patients, and it was found that it only provides risk ranges for number of B and M features present, but facilitates clinical triage in an absence of electronic devices. Personalized risk estimates can be obtained in second stage, and that is what has to be remembered when we look at only the sonographic parameters. So then came the publication in the International Journal Gynec Cancer 2023, where ultrasound examination, MRI or ROMA for discriminating between inconclusive adnexal masses as determined by IOTA simple rules was done in a prospective study. And what this told us is, as you decide to go compositely ahead and take all of them into account, and especially if you use the ROMA, then possibility of increasing the sensitivity would definitely increase. So that is what is important. So whenever we are having a patient of a specialized malignancy, you would consider doing whatever, of course, but what about those patients who are presenting you with a symptom or with high risk backgrounds? In those, you have done an ultrasonographic assessment. There are non-physiological findings. Expert ultrasound assessment or IOTA ADNEX model has been done. Almost certainly benign if it has come, but you have a patient who has an intermediate risk of malignancy, then this would be a patient in whom, if you try to use the ROMA here, you'll be able to identify. Now, what is our experience? Recently, I have now a data of about 50 patients in whom we used the ROMA along with the IOTA for assessment of risk in those women who were in the perimenopausal age group with an ovarian lesion. And what is very imperative in identifying or studying the ROMA is the fact whether the woman is menopausal or not. And sometimes just the absence of her periods doesn't act as an useful marker. What is very important to find out whether her FSH levels are really in the range of menopause to interpret your results correctly. So there are various such organizations in India which are helping the battle ovarian cancer. And we have recently at the Foxy started doing this screening, which would be initiated somewhere around the end of February, wherein we are proposing to look at the data where we'll be able to find whether we can involve ROMA, which involves the HE4 along with the CA125 to interpret the women's cancer situation. So in conclusion, ovarian cancer is a lethal disease with urgent need for early diagnosis. We need to find the origin of the malignant cell, to understand the mechanism of transformation, to understand the influence of risk factors on this cell. Only then a screening method can be useful and early detection helpful. And diagnostic and treatment decisions should be done according to the predictive models and the biomarkers. Thank you so much.
That was really insightful, Dr. Girija, and very well explained how the screening and prediction can happen using Roma, especially with IOTA. We'll move to another topic now with Dr. Monika Agrawal. The cervical cancer, which is the second most common cancer which is affecting women in India. Dr. Monika, we'd like to understand from you what are the reasons and when the screening has to be done for cervical cancer.
Thank you so much, Dr. Monica. I hope my screen is visible to all.
Yeah, it's there.
Okay. So we will talk about today regarding the HPV virus, that is the human papilloma virus, and its association with the cervical cancer, and how early detection will help females to find out the proper way of treatment and management of these cases. First, we will know about what is human papilloma virus. It is a very common virus, and 7 out of 10 people at some point of their lifetime may infect with this human papilloma virus. And at around 170 strain of this virus is present here, and most of them does not cause, most of them do not cause cancer. There are certain high risk viruses which usually causes human cervical cancers or the other cancers, and there are certain low risk viruses are also there which are not mainly causing malignant cancers, or we can say that, but definitely they have some oncogenic potential. So when we talk about what are the different types of high risk viruses which mainly involved with the cancer causing or with the oncogenic potential, are mainly 16, 18, 45, 31. There are the list which is already mentioned here. But among all these viruses or all these strains of HPV, the 16 or 18 has the highest risk type, which may around causes 76.7% of the all cervical cancer. And we take the 100 cervical cancers, about invasive cancer, it took about 83.2% of these total cases of cervical cancer. There are 5 genera of HPV virus: alpha, beta, gamma, nu and mu papilloma virus. Among those, most of the oncogenic potential is mainly present with the alpha viridae genera. Human papilloma virus, usually in females, if we talk about, it's the main causative agent for the cervical, vaginal, vulvar, or anal cancer, as well as the head and neck cancer. But in contrast, in males, if we say, it mainly causes the penile or head and neck cancers along with the anal cancers. So what would be the mode of transmission of this human papilloma virus? Mainly through the sexual activity. The second most common is the skin to skin contact. So if somebody thinks that if they wear condom and they will not get the human papilloma virus, by that it is not there, because it will not completely protect you, because the transmission through skin to skin contact is also there. So most of the infection, if we'll say, it is usually transient, but this virus remain for a long period even after the infection. And if it is present within the cervical layers of the cells, in those state, if it remains for a longer time, it may cause pre-malignant conditions or the later on cervical cancers. There are certain strains which are prevalent in India. In North India, if we say, it is 16 and 45. In South India, it is usually 35. And if we talk about in Central India, it is, the studies say that the HPV type 16 is very common among those. Now, this is the way how human papilloma virus spread in the cervical, in the cervix. This is basically mainly primarily affect the basal cell, and later on, weeks after weeks, the viral replicate and ultimately it infect the, present with the invasive cancer after 10 to 13 years, reaches to the integrate with the other cervical cells. Now, because HPV is commonly associated with the cervical cancer, and cervical cancer as a whole, if we'll talk about, it is mainly affecting the age group of women 15 to 44 years. And this is the second most common cancer among women, but it is the third most common cancer among all the cancers in India. And if we'll talk about, it contributes about 25% of the global death. Depending upon the stage of the cervical cancer, the survival rate among women is usually for 5 years survival. If we talk about, in the very advanced stage, the survival rate is only 7.5%. In contrast to the localized cancer, if it is there, the survival rate would be 73.2%. So what are the risk factors usually associated with the cervical cancer? Why we have taken HPV along with the cervical cancer? Because the 70% of the cervical cancer, the most common causative agent is HPV, that is the human papilloma virus. Means 4 out of 5 cervical cancer in India is because of the human papilloma virus. There are certain other risk factors are also there. Means if the intercourse is started at the early stage, frequent births are there because of the low socioeconomic status, and smoking. There are certain other things also, they are the risk factor. But the most common risk factor for the development of cervical cancer in India is human papilloma virus. So we can say it is again, as with the ovarian cancer, which was talk about Dr. Girija, that ovarian cancer is also a silent killer, as well as cervical cancer is also a silent killer. But the most important thing, or most significant thing associated with the cervical cancer is, it is 100% preventable if it is properly diagnosed, or if the person is vaccinated on time. So even after the treatment, if there are certain things we can say, so we In case of cervical cancer, it is said that every 7 minutes, a woman lost her battle to cervical cancer, but it is preventable. But the truth is, if we say in India, the girls which are those who are vaccinated is less than 1%, and the women going for the cervical cancer screening is 1.9%. And it is different in urban as well as in the rural areas also. In urban, the percentage was 2.2%. And if we talk about in rural areas, the cervical cancer screening percentage was only 1.9 in certain studies, which I have read. So what we should do? So in this case, the key is prevention. How we can prevent cervical cancer? There are certain tests available. There is vaccine. There are vaccinations available. There are different kinds of vaccines are also available. If we talk about various tests, so what are these tests which we can use as a screening test? Our first is the pap smear test, in which basically it is usually done by the healthcare provider, in which the cervical smear is taken, and in which the histopathologically will be able to find out any changes are present in the cervical epithelial layers. The second test is the human papilloma virus DNA testing, in which usually we detect the presence of human papilloma virus, which is of a high risk. In this test, usually we do the real-time PCR testing. There are certain other tests are also available. It is going to depend on the settings. It is a high risk settings, or the basic settings are there, or there are enhanced settings according to the availability, such as in the there are basic settings where now the HPV DNA facility is there, or no, there is a pap smear facility is there. In such condition, there are certain other tests are also available, like visual inspection by acetic acid or Lugol's iodine, that is VIA, usually we say about that. And the other preventive method is the vaccination. Vaccination is very, very important in prevention of cervical cancer. There are four basic vaccines which are basically approved by Indian government. We can say that is the Cervavac is there, Cervavarix is there, and Gardasil, which in which the Cervavac, if I'll say, we can proudly say that it is developed by the Indian manufacturing company, and most probably government is trying to include this vaccine in a universal immunization program to vaccinate 9 to 14 years of age of girls in this. So when we talk about the cervical screening testing accuracy, if we say about the cytology, the specificity is around 96.6%. It may go up to this. And in case of VIA, it is around 85.58%. And for HPV DNA testing, it may go up to 88%. So when we combine two methodology together, like if we are going for cytology as well as for HPV DNA testing, the specificity as well as the sensitivity may go very high. There are studies which says ki if only one test was being done, the missing population was more than 2000, those who later on developed cervical cancer, if only one methodology was used for the diagnosis, for the screening of cervical cancer. So what are the recommendation by the Federation of Obs and Gynae Society of India, when we should start screening? What is the end age for the screening? So age to start is 25 years if it is a good resource setting. If the HPV DNA testing is available, pap testing is available, then 25 year is a good time to start this. Otherwise, if we talk about if we combine all these settings, then definitely 30 year will be the universal recommendation. What is the age of end screening? It is usually 65 years. It is mainly for the three at least cytology negative results consecutive, or HPV DNA within 10 years, two consecutive tests must be negative. And these should be performed within a 5 years of span. So what would be the testing screening interval? Again, it will depend on the availabilities of the test. If it is a good setting, basic setting, then you have to 1 in 3 times in your lifetime. But if it is a very, if we can say it is a maximal testing facilities are there, then every 5 years you can go for the testing. And as per WHO, if it is a limited resource setting. In those conditions, in the age of 30 to 49 years or in the age of 30 to 65 years, at least 2 times testing or screening is required at the age of 35 as well as at the age of 45. So is this requirement of a screening once the female has been done with hysterectomy and with the cervix removal? No, there is no recommendation, because ultimately you have removed the cervix, so there is no requirement of cervical cancer screening in such patients. What about if the female is HIV positive or a female is immunocompromised? In such cases, the early age of screening is 25 years, and in place of every 5 years screening, you have to reduce the screening time from 5 to 3 years. So every 3 years, the female will go under the screening of HPV DNA virus as well as by the cytology testing. So but there are certain challenges when we talk about the HPV or cervical cancer screening in India specifically. First of all, there is a limited access to healthcare. If we go in the mountain areas, if we go in the remote areas, there are very few facilities are available for the female to go and get tested for or get screened for that. Even as we have already seen that only 1.59% female go for cervical screening testing. So there is a lack of awareness is also there because of the illiteracy, maybe because of the financial constraints are also there, and sometimes the distance. Because if the clinic is 50 kilometers away, no female will go for the screening test, because most of the females in India are negligible about their health conditions. And there are certain social barriers or social stigma is also there कि यदि मैं कैंसर से डायग्नोज हो जाऊंगी तो my family will leave me. My family will leave me alone. My husband will leave me alone. So this is something. Social barriers are also there. There are certain religious beliefs are also there. And sometimes, most of the time in Indian, in village area or in rural areas, there is a permission is required from the husband and the other family members. Should I go for the testing or not? And even for the vaccination also, because they think if the female is get vaccinated, then ultimately she will not give a birth to a child. So this is a common belief in the society, which gives challenges for the HPV as well as the cervical cancer screening. But if the government is able to address these issues or these barriers, we will be able to reduce the cases of cervical cancer incidence. So in this case, there is one initiative which is taken up by WHO in November 2020, that is the Cervical Cancer Elimination Initiative, in which 90, 70, 90% formula was taken. They are the 3 key pillars in which the 90% of the, by 2030, it has been proposed that 90% of the girls should be fully vaccinated till the age of 15 years. The 70% of the females at the age of 35 as well as 45 years will be screened for high performance test, either with the HPV DNA PCR or by the cytology. And the 90% of the females who are diagnosed with the precancerous condition or the invasive cancer condition will be properly provided with the adequate treatment and facility and the management. There are certain common myths which are associated with the HPV, like HPV is a disease of women, not a man, but it is not there. Both are equally affected in this. So when we talk about vaccination, we only talk about the vaccination to the female, but men should also be included in this age group. The men should also be will be provided with the vaccination. There is treatments are available for human papilloma virus. No, this disease is not a curable disease, but yes, if you have a precancerous condition or if you want to away from development of cervical cancer through vaccination, you can do that. If I take vaccine, it may cause many side effect to me, but it is not true. Only pain is there, pain and some swelling there is the possibility for certain period of time. Otherwise, there is no major problem associated with the vaccine. And if I'll take HPV vaccine, I will not be pregnant in my life. This is the common religious belief is also there, which prevent females to get vaccinated. But in majority of the cases, this HPV vaccination does not hinder women to become pregnant. So this is the certain myths and fact. In short, I want to just conclude that early screening of HPV and cervical cancer is crucial in preventing the progression of cervical cancer. So there is regular testing as well as vaccination and awareness will significantly lower the disease burden of cervical cancer, which is preventable. And nowadays for HPV DNA, there are self-collection kits are also available. Foxy is also encouraging, if the people are not able to reach to that places, they can send these samples by the self-collection kit to send the sample to the center so that they will be able to find out the person is infected with HPV or not. So together, because for HPV, we have knowledge, we have tool so that we can together beat this disease. Thank you so much.
Thank you, Dr. Monika. It was very, very insightful. And now I would request questions from the audience. Either they can raise hand or they can put their questions in the chat. We would like to have those questions. So audience, if you can hear me, you can put your questions in the chat or either you can raise a hand. If you raise a hand, I'll unmute your screens.
Which I think, Dr. Monika, I'm seeing one question. Which cervical vaccine should be taken to avoid cervical cancer? In India, there are 3 vaccines are available. That is, one is the Cervarix, second is Cervovac, and the Gardasil. Normally, the quadrivalent vaccine is safe. You can take that vaccine, which is usually against the high risk group of viruses, which prevent you from the cervical cancer.
Any other questions, audience? Because we covered 3 important topics. One was cardiovascular diseases, which we can use HS troponin I as a risk stratification marker. The second topic was by Dr. Girija, where she talked about ovarian cancer, where Roma index together with other biomarkers can be used for early screening. And the last one was HPV testing by Dr. Monika Agrawal, where we do have self-collection kit and vaccination available. So early diagnosis is the only key where we can detect the people early and then we can save the patient from being chronic illness and ultimately the mortality. So women health is very, very important as we know, and all these things where we have touched upon the 2 main topics of cancer and cardiovascular disease, which is the major reason of mortality in female, can be talked about. And if we go for the early screening, they can be definitely cured and patient can have a better life along with their family, and they can further contribute to the society. Just to inform the audience, at Dr. B. Lal Laboratory, we all have all these tests available with us. We are doing Roma Index, we are doing HS troponin I, and we are doing HPV testing along with the self-collection kit, which Dr. Monika Agrawal just informed. These are available with us, and we are launching one program called as She Rose, where we'll be helping the females for early diagnosis and prevention thereon. So if we don't have any other questions, we would like to end the session. Thank you so much, everyone, for joining in. I would like to thank all my panelists, Dr. Girija, Dr. Tina, and Dr. Monika Agrawal, for being with us and giving such an insight on about the very pertinent topics of women health. Thank you so much.
Thank you so much, Dr. Monika.
Thank you. Thank you so much.